Thank you. Let me open this up for questions from the audience, please. And if you don't have any, I've got a few.
Good afternoon. That was a wonderful presentation. Thank you. I'm very involved as an advocate for palliative care. How applicable is that to what you're talking about? It doesn't exist much in terms of home-based care yet, but that seems to be the most progressive, and certainly I've enjoyed it. My husband and those many people who have had access to Mount Sinai's very progressive model has both, had their late pre-hospice care managed in such a way that does all the things that you're talking about. But there aren't many that do it home base because of the cost. So how can that inform or, produce what you're talking about?
Well, let me start, and then I'll let whoever wants to jump in. But one of the things that I try to think in my head about this new language we're using about advanced illness and advanced care is that in a way I'm trying to look at it as stretching out. It's not just end of life.
Yes.
It's not just hospice. It's not just palliative care, of course, because palliative care can be beneficial throughout an advanced illness. So let me just preface their comments on your question with that for me at least, this is something that some of the best healthcare systems out there now have systems to identify individuals that they believe have advanced illness, and that they should kick in and start making sure they're getting the kinds of coordination for the care and the whole range of services that they need, including in the community, specifically trying to keep them out of hospitals and other healthcare facilities if they don't want that and if they don't need it. So let me, does someone want to say a little bit more about the palliative care piece? Mickey?
I will.
Why don't you start, Ivan?
Okay, you'll follow. You'll do something too. So, for us, that's the palliative care model is a great model for an interdisciplinary team. Like the idea, the concept of the way the palliative care model works, and the theory that is being put into practice in a variety of locations. It's certainly not comprehensive across the country at this point, but certainly there are some great best case scenarios to look at for that, is really with the patient at the center and a team that surrounds them, whether that's doctors, clergy, family, social workers, the whole role. And ideally, if we could make sure that the healthcare community, the general healthcare community remains a part of that dynamic, then that would be ideal. But if you start seeing like some of the general healthcare members, for example, if after curative treatment is finished, the oncologist disappears, for example, then you're losing all of the best possibilities around what it means to have that team that has known that patient that entire period be a part of those treatment decisions, not just during curative, but during palliative and during end of life. And that's what we're looking for. And so the best model for this is the change that's happened in how we give birth to babies in this country, right? Like the significant impact is the difference with how, there was a period where all babies were born of one of two ways, in the same situation, in the same place, and that's the way it was done. And it was a very medical model. And that has been transformed to a patient-centered model where the patient drives often where the baby is born, how that process happens, who's a part of it, what's the model. So if you're really looking for a model of what good advanced care or advanced illness planning could look like, look to the beginning of life. And the miracle that we believe the beginning of life is the same miracle that we should experience at the end of life. If we have that happening, then we will have truly patient-centered care. Because people will want to be involved in it. The team would want to be a part of that precious miracle that is happening. Did I get on my soapbox? Sorry.
Yeah, okay. Anyone over here have a question? Okay, in the back there, thank you.
I was just going to
recommending palliative care, and then they were using the word hospice, and I was equating them as one and the same. Along with the question just asked, if I had chosen palliative care, would she have had to receive that in a hospital environment, or would I have ever had a choice? Do you automatically then bring it to a nursing home? What's the choice for that? Because I eventually chose hospice, and which was very hard decision, but.
It varies. Yeah, that's,
The answer is it varies, and I'm not a clinician, but what I will say is that, I mean, there's probably other folks in the audience that knows, but
It was here in Chicago. She
Yeah.
was in a hospital here in Chicago. Would she have, if I had chosen palliative care, do they have to keep them in the hospital? Or you're saying they
No.
Absolutely not.
no.
to a nursing
No.
home or whatever?
Right. In fact, yeah, in most hospice care, for example, a lot of hospice care now does not happen in a facility. It happens at home. Yeah. So palliative care, as an extension of that, it happens in a variety of formats in a variety of places, and it just really varies based on who your healthcare provider is, what your community experience is, what your individual relationship with your doctor and team are, and what their knowledge base is around palliative care, what they know about it. It's a new specialty, so it's not like it's had as much time as other specialties to really filter through the whole universal healthcare system. So what's true about it, and I appreciate you standing up and speaking to this, is that it requires advocacy on the part of the patient and the family, or the person and the family caregivers, in order to ensure that it happens in a way that the person and the family care unit want to have it happen. But it's available in a variety of circumstances. It also depends on how you're going to pay for it.
well, and I was just going to dovetail on that in Medicare, palliation and palliative care is largely limited to the hospice benefit, and we all know what it takes to largely limited to the hospice benefit. There's very little reimbursement outside of the hospice benefit, if at all, for palliative care services, which is a serious problem. And I would say that there are many places across the country where it goes far upstream from the hospice benefit. We have folks in SeaTac, Aetna in particular, that's now in their commercial population, which their advanced illness sort of cohort in their commercial population isn't huge, but in their MA population it is. And they've gone way upstream with palliative care and hospice, and have done very well, and have a lot of data coming out. But it's new and it's innovative, and that's the sort of learning curve that we need to be on.
MA, Medicare Advantage.
I'm sorry, Medicare Advantage.
Yes.
I just want to tag along to this one's comment. This is the messaging problem that I don't think, I'm speaking from a family caregiver perspective, family organization perspective, I'm from Family Caregiver Alliance. The line between advanced illness, palliative care, hospice is not clear to consumers. I've often mentioned this to doctors. I get a lot of eye-rolling behavior about, why don't I know this? I'm thinking, I'm fairly sophisticated, been in the field for 30 years. I don't understand where that line is crossed and who advocates to cross it. This is the main messaging issue. It's very, you say it varies, everyone's lost, because it varies. And so I just need to point out, this is the critical issue when you're out there in the field working with families, actually.
Right.
Very good.
I'm actually, just to clarify, I concur with you in terms of how the consumer experiences it, right? So that's different for providers, and we're a consumer organization, so it's different for providers. Many providers are establishing those definitions and actively working within those definitions. SeaTac being one of those is being, getting very specific about the definitions and the time periods and the nature of the illness and what constitutes what phase or stage. The service delivery around palliative care, like how you would access it, how you would get it, that's what I was saying would vary. And do you want to speak to the?
Well, I was just going to say that, and I'll just speak from SeaTac's perspective, that the advanced care term, yeah, there's a lot of educating that needs to happen on this issue, period, I would argue. But the advanced care term is sort of a nice term because it really is population focused and not service delivery focused, so or advanced illness. So it's saying let's target a very, very specific population which has all sorts of needs, from chronic care management to better care coordination, leading them into hospice. So it's sort of a nice term, and yeah, I think we can all agree there's much more education that needs to happen around the term, but it's sort of an umbrella term, and that's why CTAC is so diverse, because they say, yes, this is the population that we need to focus on. We all bring different lines of service delivery to that population, including home health, skilled nursing, et cetera.
Even that population, though, is kind of like pre-hospice. So that, it's like immediately pre-hospice. So you're beginning to see greater definition that's making it possible for, care providers to, who are not part of the medical system, be able to negotiate. But from a consumer perspective, like our consumers are like your consumers. What they know is something is happening right now, and I need help figuring out how to deal with it. And that's the experience that they're having. And
Let me try and get a few.
Oops, I'm sorry, I will be
shorter
briefer.
answers from
Yes.
this panel. Right here.
Don't
Thank
blame
you.
Lynn. She's been great.
I used to work in a large teaching hospital, and so I, as a clinical social worker, and was involved in a lot of end-of-life decision-making, as well as personally dealing with it when my own husband had cancer and eventually passed away with hospice. And I understand your emphasis on teaching the public, but I think it really needed so much emphasis on communicating with the physicians.
No
Because
question.
personally, what I've experienced is, one, they don't like to deliver bad news and they are terrible at it. And two, they don't want to give up. And some of it may be wrapped up in their own ego, or they're just afraid that they feel like a failure or something. And I worked on an oncology before, and I know they don't start out with giving you the lowest level chemo. They give you the best shot. And when they start offering you number 2, number 3, number 4 chemo, we all knew that what was going to happen, which was that. But the physicians just kept giving it, and the patients often are going to follow what the doctor says. They're so intimidated by the whole healthcare system that it's really hard to find people that are going to stand up and advocate for themselves.
I'm going to just thank you. I'm going to just take that as a comment that we all agree with you on, and I'm going to go to this gentleman here.
I applaud your focus on the importance of person-centered care, but just a brief placeholder that true person-centered care isn't just about the care delivery system, it's also about the built environment within which the care is delivered. It's very hard to deliver true, supportive, healing, person-centered care in an institution that was built as a medical clinic, first and foremost by, with, and for administrators and clinicians, and not by, with, and for families and residents or patients.
Ladies and gentlemen,
Agree.
applaud that man. That is Robert Meyer, who's from the Rothschild Foundation, which has done a ton of work on transforming to patient-centered care in facilities. And he actually reminded me this morning of a great statement from the disability community, which is nothing about me without me. And I think that just really applies to this whole subject matter and that whole conversation. So thanks for bringing that back to me this morning.
Anyone in the, okay, go ahead, ma'am.
In terms of the advanced directives, wanting to honor the person's wishes and absolutely wanting to follow that, that person's directives. But considering that the United States is becoming increasingly diverse, there may be some groups in which that choice, that right is left to a quote-unquote higher power. I don't know if you talk about this, I arrived a few minutes later, but how do we even start that conversation so that we can try attempting to get an advanced directive?
No, you start.
go ahead, go
No,
ahead.
you haven't spoken. Go for it.
I think these are critically important issues as our population ages and becomes more diverse. And I just think that we need to start having these conversations in different cultural groups and different diverse communities about how care at the end of life, how we want it to happen, and what's important to you. And if it's from a higher order, and that's the directive, then so be it. It should be as the person wants. Just like in true person-centered care, if somebody says, I don't want to die in the hospital, then get that person out of the hospital and get them home as soon as possible so they can die where they want to be. So I may not be as articulate as I want to be right now, but I think you have to identify the faith and the cultural norms of the individual and the family and work from where they are. How social work of me to say that.
Andrew, do you want to comment on CTAC's involvement with the diverse communities in the various faiths? And
Absolutely. So CTAC, it's such a critically important point, and I would just say that, you know, we ignore people's faith on this issue at our own peril, really. I mean, Gunderson in Lutheran in Wisconsin, arguably, Respecting Choice is arguably the most successful, certainly on a penetration level, certainly the most successful advanced care planning program in the country, does it through churches and through community leaders. That is how they do it. Bud Hammis, Dr. Bud Hammis, who designed the program, says he's become a good friend and a mentor of mine. He says, none of this happens in the hospital, it all happens outside of the hospital. And there's just again, it goes back to that sort of normalizing of the conversation. But CTAC, in recognition of that, actually has a faith-based subgroup that is multi-denominational, and it's everybody. It's Catholic, Jew, Muslim, and the conversations that happen in that group are just incredible. And they're probably one of CTAC's greatest strengths, I would argue.
was there someone here in the front over here? Did anyone have any other questions? Sir?
I just think the biggest headwind you're going to have is that the thing you have to change is the societal acceptance of death. Society just expects, give me a pill to fix that. What, I've got cancer, you're going to treat it and find it. And whereas society, at least for the past few decades, all the general session members have talked about, you know, we're living so much longer now that's to be celebrated, but the society and the current just do not accept death. You know, I've lived that through two parents that have died and a grandmother who lived beyond their two. It's only after experiencing that you realize you just have to accept death at some point. And that's the conversation that
Thank you, Lynn.
You raise a very good point. What we haven't mentioned today, which I was so struck by, was at President Obama's inauguration speech. You'll remember he actually said, and you wonder which is the staff person or was it him that got it into the inauguration address, you know we're all going to die. He said that, the President of the United States. That's huge. He said we're all going to die. I mean, I was just flabbergasted. It's like, yes! I mean, that was huge. And that's what we need. We need our leaders in all walks of life, in the faith-based community, in politics, in the employer sector, to have these conversations and have the acceptance.
And just to add to that, I mean, if we can get to the point where we recognize we're all going to die, the next thing we have to recognize is that we may have some choices in how we're going to die, and what the quality of our life will be in relation to the length of that, how much longer we're going to live. And that's really a major educational piece, I think, that we're just trying to push healthcare providers to have those appropriate conversations with the patient, the person, and the family.
Thank you.
There's also, you know, I mean, I'll say we're an organization that deals with death all the time. We're not a hospice, but we look for care and choices at the end of life, and we try to expand those choices. And we're a consumer organization, and that's made it very difficult for us as an organization because we're extremely open about death. We're extremely open about our position on being able to have the broadest possibilities around death and the broadest comfort and care as an expression of how people want to live. And for us, we've suffered as a result of that. So, I mean, as an organization, there are tables that we can't sit at because of that experience. That's only going to change, and someone talked about medical providers' education. It's only going to exchange, I think it's going to change as a result of people our age confronting the experiences that we're having with our parents and saying it's either going to be like that because it's such a wonderful death, or no way is it going to happen like that for me because it was a horrible death. And we're going to have this conversation whether people want to have it or not, and we should be honest and transparent about it and talk about what it really is.
Does our age include 30-year-olds?
Yeah.
Yes.
No, you're a little.
Maybe you be the last, since you started us off. Why don't you be the last question as well?
That's very kind. Well, I just wanted to say that, as you were talking about inviting stories to be hosted, and some of the best stories, I think, that would bring people in to something that is otherwise forbidding when you're just talking about death, is experiences that people have had in advanced states of advanced illness, when their treatment desires are and goals are followed. And I find that when I make a speech about the last week of my husband's life, when our palliative care doctors gave him that answer when he asked how long do I have, and I then said, would you like to do something wonderful? And he said yes. He could hardly speak at that point because he had cancer of the throat. And we went to a jazz club, and it was this magical evening. And when I tell that story, people just weep in the audience, and they get all, happy because, oh my God, if it could only be like that with my mom or my dad. And I'm sure there are many people who have those stories. So that might be a kind of story to encourage. It's not as forbidding, and it's
Right.
actually very endearing.
Yeah, we try to model both the beautiful stories, the good deaths, and the deaths that are not so good, in both of them. Right now we're looking for unwanted medical treatment stories, but at the website there are also stories of folks who had really wonderful experiences at death.
Well, let's thank our panel one more time, if you would. Thank you all for joining us today.